Not you.
Okay. Hello, everyone, friends. Happy Sunday. I'm Dr. Ruth Delicarpini here today on behalf of a global summit. This is our Sunday podinar, and we have Dr. Vipul Varma here with us, and he'll be talking about space infection mysteries. Dr. Varma is a dentist, a maxillofacial surgeon, and an implantologist with an impressive resume. And I spoke with him a few minutes before the podinar. So today he will be presenting some instructions, protocols, and information on how to diagnose and manage infections in some very interesting areas. Dr. Varma, do you want to talk a little bit about yourself before we start?
Yeah, definitely. First of all, I would like to thank Global Summit and Dr. Ruth for such a beautiful introduction. And my name is Dr. Vipul, and I'm from India. I'm practicing in the city uh, Agra. And the topic I have chosen is space infection mysteries, and because it's pretty common, and I'm going to cover a little bit about the anatomies and the different space infections we encounter in the facial region, and not completely in the neck region, but mostly related to the orofacial region and their management. What are the antibiotics we usually prescribe, and how and what protocols we follow. So this is what I'm going to cover in today's topic.
This is extremely interesting for me personally as a general dentist, but I'm sure a lot of implantologists and more advanced doctors will love to hear what you have to say about this amazing topic. So, if you want to get started with your presentation, I'd love to give you the full screen and stop my sharing right now and just listen to you. Very interesting. Thank you.
All right, let me share it. The screen is visible to everyone.
Yes, perfectly visible.
All right.
Then maybe we'll ask you a few questions later. I'll check the chat in the meantime. So if everyone would like to ask questions to Dr. Vipul, you can write in the chat box, and I'll keep up with that during the presentation. Thank you. The microphone is yours.
All right. Thank you very much, Dr. Rohit. So, good morning and good evening, everyone. And so, the topic is the space infection mysteries. So, in the today's topic, we'll be talking about what you mean by space infections and how the host defense and the infection manages, balances, and what are the microbiology of the space infection, polymicrobial, and what are the particular organism which is involved in this, and what antibiotic therapy we give, what empirical antibiotic, what definitive antibiotic we give, and we will talking about the anatomy, little bit about the fascias of the head and neck region, and then major things are the classifications. So we'll be talking about the maxillary space infection classifications, mandibular, primary, and secondary complications as overall and the management. And in the end, I'll be concluding it and I'll be available to answer your questions. So facial space infection. So the facial planes are the potential areas between layers of fascias. These areas are normally filled by connective tissues. So whenever this infections happens and which when these spaces, connective tissue spaces, gets invaded by infection, it leads to the formation of all the pus and locules in those spaces and leads and give rise to facial space infection. So these facial planes are offers anatomic highways for infection to spread superficially to deep planes, and only antibiotic availability is very limited due to the poor vascularity in these kind of cases. So how these infection spreads through the space infection. So it spreads through the lymphatics, spreads through the blood, through tissues, and there are various factors which influences the spread of infections are the how virulent the organism is, pathogenicity of the organism, immune status of the patient. This is very, very, very important. So the patient, if the patient is a diabetic, having a poor blood sugar control, HbA1c around 7, 8, or more than 9, or immunocompromised patient, long-term steroids are on a high risk, and malnourished patients. And the important thing is also anatomical, like the thickness of the bone, which is adjacent to the tooth, which is also plays a major role. The muscles attachments, position of the muscles attachment, relation to the root tips are also very, very important, and it differentiates between the extraoral swelling, intraoral swellings, and different type of neighboring space infections. So moving on to the anatomic considerations, what we have the muscle attachments. In that posteriorly, we have a buccinator, which is a major muscles, and which is at a mid-root level. And anteriorly, we have a intrinsic lip muscles, and rhizoids, we have at the apex. In maxilla, if the infections is above the attachment of the muscles, if it gives rise to the extraoral space infection. But if it's below the muscles attachment, it's mostly limited to the vestibular space infection. In mandible, if the infection is below that attachment of muscles, it's more give rise to the extraoral. If it's above the muscles attachment, it's mostly intraoral. So what are the predisposing factors? So the most common predisposing factor is the dental caries, long ascending dental caries, grossly decayed tooth, periodontally compromised. Periodontal infections are the major predisposing factors. And the second thing is body resistance. If a patient is immunocompromised, as I mentioned earlier, are at high risk. And the third most common is a trauma. Trauma could be a dental-alveolar trauma, to a pure dental trauma, to a skeletal trauma, are also at a high risk. So what are the primary signs and symptoms of these infections? Where there will be, you'll encounter redness, there will be a rise in temperature, there will be erythema overlying the tissues, there will be a pain, there will be a loss of function, there will be a lymphadenopathy. So moving on to the microbiology of the space infection. So we know it's a polymicrobial, which is 70% comprises of mixed, 25% is all about the anaerobic, and 5% is about aerobic. So in aerobic bacteria, mostly it's comprises of gram-positive cocci, streptococcus and staphylococcus. And in anaerobic, we have Peptococci and Fusobacterium and Prevotellus. What are the indications for antibiotics? So the indications in case if there is a soft tissue wound, there's a pericoronitis, there's a fractures, there's a toxin sign and symptoms, the temperature, rising temperatures and all abscess in a systematic compromised patients, they are the indications for the antibiotic in such cases. And how we do the selection of that? We selection based on number one thing is identification of the particular organism which is involved in that. That is very, very important, because most of the time we randomly give broad spectrum antibiotics and patient end up getting resistance towards it. So the number one thing needs to be done is a pus culture and antibiotic sensitivity drug test. These are the number one things we need to do the moment we see a pus coming out from any wound, in no matter where it belongs to. So that's the number one thing we need to do. The second thing is that needs to be a bactericidal drugs. That's better. Of the narrowest spectrum is preferred, because we have to see we are not drug abusing the patient by giving a broad spectrum antibiotics. So the least toxic antibiotic should be selected, and the cost of antibiotics also matters. We have to choose from the affordable to the more expensive ones. So moving on to the stages of infection. So we have from the stage 1 to stage 4. It starts with the inflammation with the early spread. Then we give rise to the cellulitis within 0 to 3 days. Then abscess. After 4 days to 7 days, more towards the abscess. Then it starts resolving and it leads to stage 4. So moving on to the general principles, how we manage these kind of infections. So number one is that remove the cause. That is the number one thing. The tooth which is giving the problem needs to be removed. Second thing is establish drainage. That needs to be done. IND needs to be done. And we have to start an antibiotic therapy. We can start an empirical antibiotic therapy in the beginning and wait for the pus culture reports to come back. And in case if everything looks fine and the particular antibiotic therapy is responding good and patient is better, then we can continue the same empirical antibiotics, or else, in case if it's not working, then you have to look for the definitive antibiotics. So I personally prefer IV antibiotics initially, and patient if responds well to the IV antibiotics, I switch to orals now. And the fourth one is very important. Another important point is the supportive care. We need to hydrate the patient very well. So the IV line needs to be secure, and including a proper rest and nutrition. The patient needs to have a very good protein diet and good amount of IV fluids. So the early decompressions has the following benefits. It prevents the spread of infection. That is important. Prevents the necrosis of the tissues, prevents pressure in the tissues, and to get rid of toxin discharges and all. It's let the antibiotic to work better, improves the drainage by opening the lymphatics and vascular channels, and allow the proper perfusion of blood through improving the delivery of antibiotics and definitive elements to the required sites. And the last but most important point is it's prevent the further complications, because space infections give rise to complications, and those complications we really can't afford. Moving on to the most common method when it comes to the IND is a Hilton's method of abscess drainage. So this needs to be on a tips, like how we perform a Hilton's method. So usually by using the 11 number BP plate, we on the most fluctuant point, we create a stab-like incisions, and using a sinus forceps, we open up all the locules. Make sure you break the locules and let the pus comes out, flows out, oozes out from the site of interest. And then once you're done with that, put a drain, suture the drain, and leave it open, or let the pus slowly comes out from the site in a couple of days. Moving on to the extraorals, we encounter a lot of locules and all that. So the same method and principles are usually followed. So the most important point, and why I have written in a separate slide, is this, because it carries a lot of weightage, and the importance is the removal of the source of infection. It's compulsory apart from drainage. So mostly a lot of people, what they usually do, they just drain the surgical site, they drain the particular area of interest, and they leave the particular tooth over there. In case if it's not restorable, remove it off on the day 0 along with the IND. Otherwise, there is no point of keeping it over there. It's going to give rise to more complications. So just remove it off on the day 0 along with IND, or if you think it's restorable, then go for root canals. But I personally prefer removing it. Moving on to the medical management, the supportive management is mandatory in the form of antibiotics, anti-inflammatories, and electrolytes. So what are the principle of choosing an appropriate antibiotics? So needs to be checked after antibiotic sensitivity. As I already mentioned, least toxic, narrow spectrum, and with a good drug history. So what are the choices we have in the empirical antibiotics? We have, if a patient is inpatient, if patient is admitted in your practice in hospitals, we usually prefer ampicillin, amoxicillin. If patient is allergic to amoxicillin, augmentin, then we prefer clindamycin 600 mg. If the allergy is mild, then we can go for any cephalosporin groups drugs. Whereas the empirical antibiotic of choice is augmentin, ampicillin, augmentin, IV or oral, depends. Moving on to the supportive therapy. Supportive therapies also plays equal and important roles along with antibiotic therapy, and it needs to start from day 0. And it involves those modalities which helps the patient its own body defenses. So we have to make the patient also strong enough to fight against the organisms. There's no point of just keep giving the antibiotics. We have to make the patients also to be strong enough. So we have to administer the antibiotics. Hydration of the patient is very, very important. You have to be through IV route, maintain adequate nutritional status, high protein intake. That is very important. Analgesic, bed rest, application of heat in the form of moist pack, advised mouth rinses, and dental management of the particular tooth I've already mentioned. So what we need today, we need to increase the daily calorie intake for a patient up to 13% for each degree rise in temperature. so that the patient will get recovered very, very quickly, because there'll be a lot of breakdowns, and we have to give a high protein diet to the patients. Personally, for anything, post procedures, we have to give high protein diet, and it has to be 13% more calorie index of whatever he was taking. So moving on to the classifications we have. So now it's going to be very basic, the basic anatomical structures, basic different type of spaces we encounter in a daily practice, but the overall principles are the same for all the space infections. The only difference will be the IND, the location where we do incision and drainage. Otherwise, the antibiotic therapy and supportive therapy are going to be the same for all the space infections. So moving on to the classification of spaces. So we have a primary spaces and the secondary spaces. Primary spaces are the one which are direct involved with the tooth. Can be canine space, also known as infraorbital space infection, buccal, infratemporal. In the mandible region, we have buccal space, submental, submandibular, sublingual, and the secondary spaces are the indirect one, and which usually take place through the primary ones. So when we don't address the primary on time, it can give rise to the secondary one through the muscles, through the attachments, or through bone. So it can be a mesenteric space, pterygomandibular, temporal, deep temporal, superficial temporal, parapharyngeal, prevertebral space infections. So this is the same flow chart for all the space infections. In the face region, we have the buccal, canine, mesenteric, parotid. In the suprahyoid, we usually divide it based on the hyoid bone. In the suprahyoid or below the hyoid bone, infrahyoid. So we got sublingual, submandibular, pharyngomaxillary. Infrahyoid, we have pretracheal space infections or the neck space infections, and then later on we go to the deep neck space infections. We got an retropharyngeal and carotid sheath space infection. So moving on to the buccal spaces, buccal space infection. So buccal space infection will be a typical picture. The patient will present to you with a good swelling around the cheek region, and the important things are the boundaries. Anteriorly, it'll be corner of the mouth. Posteriorly, there'll be a retropharyngeal raphe or masseter. Superiorly, there'll be a maxilla or infraorbital space. Inferior to that, there'll be a lower border of mandible. Medially, it'll be buccellator muscle, and laterally, there'll be skin of chin. So what will be the contents of this buccal space infection? There'll be a buccal phallopad, there'll be a Stenson's duct, parotid ducts will be there, anterior and transverse facial artery. And what are the likely source of infection for which tooth it usually happen is maxillary and mandibular premolars and molars are the responsible ones to which mostly give rise to buccal spaces. So clinically, the patient will present with an extraoral swelling over the cheek region, and initially it can be a vestibular abscess, or it can present as extraoral swelling. So the treatment will be an intraoral horizontal vestibular incision. So there is nothing extraoral we have to give for buccal spaces. We have to drain it intraorally. There's a horizontal vestibular incision which needs to place through the oral mucosa in the cheek in the premolar and molar region. Make sure we don't jeopardize the buccal phallopad while giving this incision. And after that, once you drain it, we can secure a drain in that, or we can start the antibiotic prophylaxis. Moving on to the canine space. Canine space is also known as infraorbital space infection, which anteriorly lies by nasal cartilages, posteriorly by buccal space, superiorly by the labia superialis muscles, inferiorly by oral mucosa, medially by quadralis labia superialis, and laterally by levator anguli oris. So likely source of infection is maxillary canine and posterior molars. Mostly it's because of the maxillary canines. So clinically, how the patient will present to us? The patient will be with the obliteration of the nasolabial fold. So this is a very important point. So in case of patients, there is the obliteration in the nasolabial fold region, is most likely you have to judge. You have to differentiate between the buccal and the canine then, because buccal there won't be any obliteration of the nasolabial fold. There'll be a swelling lateral to the nose region. There'll be swelling of the upper lip. There'll be erythema in the upper and lower eyelid that may close the eye. It'll be difficult for the patient to close the eyes. So what will the treatment? So we have to give a mucosal vestibular incision in the incisor and canine region intraorally. There's nothing extraoral we have to give for this type of space infection. Moving on to another submandibular space infections, which is mostly in the mandibular region, and the mandibular molars are the one responsible for this. And the end boundaries are the anteriorly, it lies by the anterior belly of digastric. and posteriorly by the posterior value of digastric, superiorly by the inferior and medial surface of mandible, inferiorly by digastric trigon, laterally by platysma, medially by the mylohyoid, hypoglossus, and superior constrictor. So this is how the clinical picture of the patient will be, and clinically there will be an extraoral swelling and there will be an obliteration of the mandibular line, which is extending to the level of the hyoid bone. So this is important between the buccal and the submandibular space infection. This is one of the characteristic clinical features. We can come to jump to a particular diagnosis based on the clinical image of a patient. There will be no trismus. That is important. If in case a trismus is there, then it's more likely to a mesenteric space infection. The mesenteric muscle is involved and it's going more deep through the muscles which are located posteriorly. So this is very important. In the submandibular space infection, there won't be any trismus. So how we do it? We do IND, incision and drainage through extraoral incisions, which is usually like a two-step incisions given over the most dependent parts. I've already explained how the Hilton's method works. So Hilton methods, we have to follow the Hilton's method. We have to use the 11 size VP blade and place a stab-like incision over the most fluctuant point and put the sinus forceps and try to break all the locules and drain it and secure the drain later on. Moving on to the another intraoral space infection is the sublingual one. Sublingual one and submandibular one. The only difference is they both space infections are divided by mylohyoid muscles. If sublingual perforates through the mylohyoid muscles, it can turn into a submandibular space infection. So this is very important. So usually anteriorly there'll be a lingual surface of the mandible, posteriorly there'll be a submandibular space, superiorly there'll be oral mucosa, inferiorly there'll be mylohyoid, and below mylohyoid there'll be a submandibular, and medially there'll be muscles of tongue, and laterally there'll be lingual surface of mandible. What are the sources? Which tooth is responsible to give rise to sublingual? Are the mandibular premolars and molar tooth, which are located above the mylohyoid muscles. If the apices of the roots are above the mylohyoid muscle, give rise to sublingual space. If the apices of the root below the mylohyoid muscles, is submandibular. So clinically, there'll be elevation of tongue. So there'll be a typical elevation of tongue. Even in Ludwig in China, we encounter the same elevation, but that is even more extreme. But in this case, there'll be a mild elevation of tongue. There'll be erythema, there'll be induration of the floor of the mouth, and tongue cannot be extended beyond the vermilion border of the upper lip. That is very, very important. So if in case the infections pass through the posterior hyoid, it's more like to submandibular space, and sublingual can give rise to lateral pharyngeal also through buccopharyngeal gap. How we do surgical management? We place an intraoral incision over the lingual sulcus at the base of the alveolar process. We put a artery forceps, we drain it. So moving on to the extraoral anterior chin space infection, which is known as submental space infection, which is over the mental chin region. And most of the teeth which are involved in these are lower anteriors, from canine, from laterals to laterals or canine to canines are the one which is involved in submental space infection. Clinically, the patient will be presented as a swelling over the chin region, which is located, limited to the point of chin. And there'll be a fullness of the submental space. There'll be limitation of swelling to hyoid bone. So it'll be suprahyoid. It's not going to be infrahyoid. So what we usually do, we go with transverse incision extraorally in the skin below the symphysis of the mandible and blunt upward and backward direction. We put our forceps and drain the pus out, and we put a dressing over it. Moving on to the secondary space infections, are also known as indirect space infection. The most common is the masticatory space infection. So these are the secondary spaces, well differentiated and communicate with each other. It communicates very well and are the dangerous one. So the most common one is the pterygomandibular space. So pterygomandibular space has an anterior buccal space. Posteriorly, boundaries are the deep loboparotid gland. Superiorly is lateral pterygoid. Inferiorly, inferior border of mandible. Medially, medial pterygoid muscles. Laterally, ascending ramus of mandible. So the most likely source of infection is lower third molars. That's the main reason why we have to be a little careful when it comes to the lower third molars. infection, when it comes to the pericoronitis, when it comes to the inflamed operculitis, when it comes to the lower third molar management, because these kind of infections, patients clinically present with trismus. That is very, very, very important. The pterygomandibular space infections or masticatory space infection patients comes with no extra oral swelling, but they'll be having trismus. So it'll be difficulty in mouth opening, sudden difficulty in mouth opening. There'll be dysphagia. There'll be a medial displacement of lateral wall of pharynx. There'll be uvula will be displaced to the opposite sides. So how we do manage it? So we do intraorally, we place a Schneer's incision along the pterygomandibular raphe. Over that region, we place a vertical slit and we drained it out. Extraorally, in case there's a very, very minimal mouth opening, hardly few millimeters, 1 or 2, 3 millimeters, then we place an extraoral incision, which is placed behind the angle of the mandible. Behind the angle of the mandible. Moving on to the another masticatory space infection, the second one is a submastotracheal space infection. So the submastotracheal space infection has a boundaries which anteriorly bounded by the buccal space, posteriorly by the parotid gland, superiorly by the zygomatic arch, inferiorly by the inferior border of mandible, medially by the ascending ramus of mandible, and laterally by the masseter muscle. And the most likely source is the lower third molar. So all the masticatory muscle or the masticatory space infections are associated with the lower third molars. Clinically, the patient will present with mild swelling over the angle of the mandible. There'll be a deep, severe thrombing pain, trismus. It's a characteristic feature for all the masticatory spaces. There'll be tenderness over the mandibular ramus, and the ear lobes are obscured. So the treatment will be an intraoral. In case if the mouth opening is sufficient enough, place a vertical incision over the external oblique line and drain it out. Extraorally, if there is no mouth opening, incision is placed beneath the angle of mandible, blunt dissection through the masticatory muscle fibers, and drain it and secure the site with a rubber or plastic drain or catheter. Moving on to the another masticatory space is the superficial temporal spaces. We have anteriorly bounded by the posterior surface of lateral orbital rims. Posteriorly, it's by the fusion of temporalis fascia. Inferiorly, zygomatic arch. Medially, lateral surface of temporalis muscles, and laterally by temporal fascia. Most likely source of infection in superficial temporal spaces are because of the upper and lower molars. And second one is the deep temporal spaces is because of the upper molars. Second and third molars are the most common tooth which give rise to deep temporal spaces. So clinically, these patients will come to you with a characteristic dumbbell-shaped swelling. Characteristic dumbbell-shaped swelling. So this is very important because this will differentiate between the buccal spaces, differentiate between the infraorbital space infection. If a patient is coming to you with a characteristic dumbbell shape, it's more likely to be a superficial deep temporal spaces. We have to look for upper third molars, upper second molars for the culprit. And when if there is a mild swelling over the temporal region and is a diffuse swelling, it could be because of the deep temporal space infections. So the treatment will be the intraoral. In that, vertical incision is made medial to the upper extent of the anterior border of the ramus. Or if it's extraoral, there will be an extraoral incision which is slightly superior to the zygomatic arch. Over that region, we are supposed to place it. Because a lot of superficial temporal arteries which runs over there, we have a lot of vascular arteries, nerves which runs in the particular region. So we have to be very careful when it comes to the extraoral incision. Moving on to the important one is the infratemporal space infections. It's anteriorly is guided by maxillary tuberosity, posteriorly by the mandibular condyle, superiorly by the infratemporal crest of sphenoid, inferiorly by the lateral pterygoid muscles, medially by lateral pterygoid plates, and laterally by the temporalis tendons for right process. So clinically, this patient will come to trismus. As we know, there'll be a swelling of face in front of ears over the TMJ and behind the zygomatic process. So there'll be a gross swelling over this region. And there will be eye will be closed and there will be a swelling over that infraorbital region too. When it comes to the treatment, there is an incision intraorally which is made into the buccolabial fold lateral to the maxillary third molar. And the same curved hemostatic is inserted behind the maxillary tuberosity and reach that particular region, and then the locules needs to be broken and all the pus needs to be drained out. When coming to the extraorally, there'll be a horizontal incision which can be placed over the zygomatic arch, and the same curved hemostat forceps can be directed in inferior and medial directions to enter into the infratemporal space region. Moving on to the few important ones in the end is a peritonsillar space infections, and clinically we can evaluate it when patients come to give rise to pharyngitis in the past 3 to 7 days having a pharyngitis, there will be severe sore throat, dysphagia, and pain over the ear region. There's a speech which is muffled and classically described as a hot potato voice, but there'll be important thing is that the trismus won't be present over there. So the needle aspirations instead of open incision drainage needs to be done. So needle aspiration is important when it comes to the peritonsillar space infections. Moving on to the lateral pharyngeal space, there'll be it's a inverted pyramidal space with the base at the base of the skull and apex at the hyoid bone. So it's more like a infrahyoid space infection, and it spreads from the peritonsillar infection, sublingual. It's an indirect, and it's a more like a complication of sublingual, submandibular, peritonsillar. So if you're not treating it well, if you're not treating in the early stages, patients not encounter it on early days, it can give rise to secondary space infections like lateral pharyngeal space infection. So clinically, there'll be a firm swelling with surrounding erythema lateral and anterior to the sternocleidomastoid muscle over the neck region. There'll be difficulty in flexing and turning of neck. Patient will find it very difficult to turn the neck around, and there'll be a trismus, dysphagia, and difficulty in breathing. And the treatment will be in such cases, this comes in a high emergency cases. We have to be very smart enough. We have to hospitalize the patient quickly. We have to start with the IV antibiotics. We have to secure the airway. This is the most important one. We have to secure the airway, and then we have to plan our surgical approaches. Incision can be made at the level of hyoid point across the sternocleidomastoid muscle. Moving on to the retropharyngeal one, it's which extend from the base of the skull to the retropharyngeal fascias, and its lateral borders are the lateral pharyngeal space and carotid sheath, and it's separated in midline by the septums. Clinical features, it's cervical lymphadenopathy, dysphagia, slight neck rigidity, breathing, neck tilted towards the involved side, and hyperextended complete innovative flexion. So what is a danger space? So it covers the entire length of space. So the one in a picture over here, the red one shows the danger space. It has an anterior border, which is a alar layer of deep fascia. Posteriorly, it's lined by the prevertebral layer and extend from skull base to diaphragm. So infection may enter mediastinum and compresses major vessels, lower airway, and upper digestive tract. That's the main reason why it's known as a danger spaceway. Carotid space infections are the one which extend from the jugular foramens and the carotid sheath to mediastinitis. Infection eroding this space may cause sudden expansion hematoma in the neck region, bleeding episodes, and Horner syndromes. So moving on to some complications which we can encounter in non-treating the space infection on an early basis or not doing a surgical approach during the right time is mediastinitum, is extension of infection from deep neck spaces into the mediastinum. It's clinically seen as a chest pain, severe dyspnea, unremitted fever, and radiographic demonstration will be there'll be a mediastinal widening. So the prognosis is little questionable when it comes to the mediastinum. Another most important complication is Ludwig angina. Ludwig angina is a form acute, rapidly progressing polymicrobial toxic cellulitis of the submandibular, sublingual, bilaterally, and submandibular. So it's involved all the three major space infection of the mandible: bilateral, sublingual, submental, and submandibular bilaterally. And when all the space infections are combined together, it's give rise to more life-threatening airway and very, very dangerous Ludwig angina. So it's rapidly spreads into like more like a gangrenous cellulitis, and clinically there will be there'll be elevation of the tongue, there'll be a gross swelling over the inferior border of the mandible, and mouth will be like there'll be hardly any mouth opening. So there'll be respiratory difficulties, there'll be hot potato voice. So when it comes to management and all that, the airway is secure. The airway needs to be secure. The hospitalization needs to be there, and the IV line needs to be secure before we plan for any surgical management. So the surgical management, mostly like a bilateral incisions and the midline incisions, according to the respective spaces, how we drain it, the same surgical plans we plan it for Ludwig and Jam, because it's a combination of all three spaces. Antibiotic therapy, we can start with augmented, any group of penicillins as empirical, we can change it to definitive if the pus culture report shows something else. Hydration is important. Ludwig angina is very complicated, and it's very risky. It can give rise to septicemia, septic shock. If not treated on time, it can lead to death also. That's very commonly seen in Ludwig angina cases. So moving on to the general management, overall general management of what I have covered so far is we have to determine the severity of the particular space infection. We have to see the characteristic and size of space of the swelling. We have to establish the presence of stress, if it's there or not. We have to evaluate the host defenses. Patient is a medically compromised, patient is diabetic. We have to control the diabetes. We have to start the patient on insulin if the normal oral hypoglycemic drugs are not working. So, and then we have to relieve the pressure. We have to remove the cause of infection. We have to remove the tooth, which is creating the problem. We have to drain the particular region. We have to perform INT on day 0 if the patient is perfectly fine, along with the removal of the tooth. We have to select the antibiotics. We have to start on a day 0 with the empirical antibiotics, or if we want, we can send the pus culture antibiotic sensitivity on day 0 itself. We have to administer steroids to reduce edema. If the patient is not diabetic, then we can choose that. If the patient is diabetic, then you have to get an opinion from medical practitioners to how much steroids we can administer. We have to keep the patient on a regular follow-up. If the patient is an outpatient, we have to follow up in 2-3 days. The patient inpatient, we have to watch the patient and have to look for the airway, edema, discharge, and swelling, and how much pus is, what amount of pus is reducing or not, and to change the dressing, and to check the drains. So thank you very much for listening to my presentation.
Here we go. That was very interesting, Dr. Varma. And as I said, what I'd like you to maybe expand a little bit more on is some tips maybe for the general dentist to understand when to submit the case to the maxillofacial surgeon. My understanding is are those procedures all performed under general anesthetics, I think, or no? Is it in-house type of thing?
We don't need a general anesthesia for a lot of space infections. For example, we don't. In case if it's a sublingual or vestibular space infections, if it's intraoral, or even though it's extraoral also, if patient is healthy and with no medical history, then we can perform under local anesthesia. If it's a secondary space infections and there's a gross swelling over there, and it's more towards the airway, then I would suggest you to hospitalize the patient just to have a secure airway for good.
So airway when it's compromised, that would be your dividing idea compared to in-house. My question also was, we always know that when there's infection, obtaining comfort for the patient, so anesthetize the patient properly, is difficult. At least this is general knowledge. What do you suggest? What's your protocols normally? Do you use normal local anesthetic? Do you have a preference?
To be honest, when there is an infection, so most of the lignocaines doesn't work over there. It's because of the pH. There's a certain acidic pH over there, and there'll be a diffusion of the local anesthetics which doesn't work. But nowadays we got something called buffered local anesthesia. We are using combination of sodium bicarbonates in the local anesthetic gels and in the solution, which has a better permeability, which has better penetration, and it gives pain relief better compared to what traditional local anesthetic solution we were using.
And what's the duration of this comfort? Like, my experience, at least, because of course I was not using buffer in the beginning, but my experience was that if you manage to obtain a comfort, so anesthesia, it didn't last very long. So the buffered formulation helps also with a good extension of this anesthetic duration.
I would say it'll be pretty decent enough to perform the procedure.
Yes. So
It'll
so
be
it is
possible.
not as long as far as duration, right?
Yeah, it is not that long, but it'll be decent enough to perform a procedure because IND, to be honest, doesn't take that long.
Right. So you have to go in and out quickly, relieve, and send them
Yeah,
home.
yeah.
But at this case, one other thing, I was reading about the changes in the protocols for antibiotic administration and in cases of allergy. And my understanding was that clindamycin wasn't the first choice anymore. It was more azithromycin. Is that your experience as well?
Yeah, to be precise, in the latest guidelines by the Canadian government, also clindamycin, they are not suggesting if a patient is allergic to penicillin. So they are
Right.
changing the guidelines. They're changing the guidelines. In the latest guidelines, they have changed that they are not using clindamycin anymore.
Right,
But
even for single use, like let's say in this case, patient has not been taking antibiotics, right?
yeah,
So in Frankfurt, in Europe, what are the protocols currently? Like you did mention clindamycin, did you not, or did I
I
understand wrong?
no, I mentioned clindamycin if a patient has a moderate to severe allergic to penicillin.
Okay, so that would be still your first line of treatment these
Yeah.
days.
I would prefer to give clindamycin 600 ml.
Over azithromycin, you would
Uh,
prefer
uh,
over azithromycin?
I, yeah,
Okay, because it's more effective, or just because the guidelines have not been put into place everywhere yet?
my first choice is going to be penicillin. My first choice is going to be augmented. But in
Right.
case the patient is showing some signs of allergic or history of allergy, then maybe clindamycin. And
Okay. So do you see it often? Because I did see penicillin allergy, and in those cases, at least from I'm talking about Italy, what we have available IV is a lot more limited than and effective, than regular. So it would favor easier the development of some space infection rather than normal management. From a small thing, you can go quickly to a big complication, because for the allergic patient, what we have available normally, it's a little more limited. But anyway, this is extremely interesting. So I really am sure that all the people that joined us today got to learn a lot of interesting reminders of how seriously things can go wrong if we don't identify, diagnose, and manage appropriately the infections, and refer or drain or prescribe the proper antibiotic. And of course, the culture antibiotic study, it's always better. And as you said, we tend to prescribe a general spectrum antibiotics, but I liked the fact that you underlined the need for a bacteriostatic, so that stops the growth of the bacteria as far as the characteristics. And probably many dentists kind of do things by habit, but it's really important to remember and remind ourselves from college that the type of antibiotic we need is something that stops the growth of the antibiotic of the bacteria, and also is tolerated well. So going for IV or intramuscular should not be something that we fear. Should be something that aggressively we start immediately, so that we don't have complications. Do you agree with that, or?
absolutely.
Okay, thank you very much for your time this Sunday, and I hope all of our viewers had as much interest in following the topic as I did. We developed and discovered some mysteries, so we thank Dr. Varma for his time. And if you have any questions, we'll follow up on the post on Facebook. Thank you.
Thank you
Bye
very
bye.
much. Bye bye.